Welcome. Thank you for joining us today. My name is Janice Butchko, Senior Project Manager for the MDS Foundation, and I will be moderating today's webinar. Thank you to our sponsors, AbbVie, Bristol Myers Squibb, Gilead, Jazz Pharmaceuticals, and Taiho Oncology for supporting this webinar program. Please note, this is a pre-recorded presentation, so the presenter will not be taking any questions. The live questions with answers segment for all participants are included at the end of this presentation. Today's presenter is Dr. Moshe Mittelman. Dr. Mittelman completed his term as the Chairman, Department of Medicine at the Tel Aviv Sourasky Medical Center in 2020. Currently, he continues as a senior consultant for hematology. He is also Professor Emeritus in Medicine and Hematology at the Sackler School of Medicine, Tel Aviv University. Professor Mittelman's research interests include basic and clinical aspects of stem cell disorders such as myelodysplastic syndromes and myeloproliferative neoplasms, multiple myeloma, and basic clinical effects of erythropoietin, translational research of malignant hematology, and applying digitalization into practical medicine. In addition, Dr. Mittelman also serves as the chair of our Medical and Scientific Advisory Board at the MDS Foundation. Thank you, Dr. Mittelman, for joining us today.
Hello, my name is Moshe Mittelman from Tel Aviv, and I was asked to cover the current status as well as challenges in the myelodysplastic syndromes field in 2023, especially following the 17th International Symposium on MDS, which was in Marseille earlier a few months ago in May this year. And I will also obviously touch some new interesting developments in the field, which were presented and published either in the other meetings, such as the American Society of Clinical Oncology, as well as the European Hematology Association. So without any further comments, I will move on. You know, often I am being asked, what is indeed MDS? Now, and I also like a very good radio program in our country, which is called 60 Seconds, not 60 Minutes, as many of you are probably aware of, but 60 Seconds on. So here are 60 seconds on myelodysplastic syndromes, which summarize very briefly the main points. As we all know, MDS, myelodysplastic syndromes, are a group of diseases which are basically bone marrow diseases. They are characterized by defective blood production, what we call dyserythropoiesis or dysmyelopoiesis. And this defective blood production is characterized both by numbers, reduced numbers usually, as well as defective function. It is usually a disease of elderly. The median age is around 74, but not necessarily. We also see patients at the age of 50 and 60. Clinically, the major and the most common symptom is anemia and anemia-related symptoms, but also other issues such as infections related to the problem with the white blood cell count, bleeding related to the low platelet count. In terms of the biology, we know today that the basis is genetic, not necessarily hereditary, but genetic. The immune system is involved. There is a great deal of inflammation, which I get to in a few minutes. And the patients are often classified as being related or belonging either to the lower risk group or the higher risk group. The prognosis is in accordance with that, as well as the treatment. And yes, there is a possible leukemic transformation. Some of the patients might develop acute leukemia in the future. This is my personal history when I started to focus on MDS. And there will be a prize at the end to those who will identify me about 3 or 4 decades ago. I would like to start with characterizing 2 typical patients. patient of the past and patient of the present. This patient was 67-year-old when I saw her for the first time in 1983. She complained of some weakness. She had kind of macrocytic anemia, very modest anemia. Bone marrow showed mild dysplasia, very minimal changes, and the cytogenetics showed characteristic del5q, a type of chromosomal abnormality, which I will get to later in a few minutes. 3 years later, she did not require any treatment. 3 years later, she became transfusion dependent, and 3 years later, the situation became more severe. Bone marrow showed more blast. It was more severe. At that time, she had high-risk disease. She required treatment, but we could give her only low-dose RC, which was available at that time. She could not tolerate it, and a few months later, she developed leukemia and died. But in contrast, I would like to present a similar patient, but in the 21st century. Look at the age 82-year-old lady who was asymptomatic, and anemia was diagnosed, very mild anemia. She was not symptomatic. 3 years later, she developed some mild symptoms. Bone marrow was similar to the bone marrow of the previous patient. It took 1 year later, when the hemoglobin started to decline, she became transfusion dependent. We also started erythropoietin at that time. She responded well for 2 years. Then she lost the response, again required transfusions. Because she had this chromosomal aberration, which I mentioned, del5q or 5q minus, she was a good candidate for lenalidomide. At that time, this was still a clinical trial. She responded very well for another 2 years. Then again, the situation became more severe. Pancytopenia, bone marrow was more severe. She was defined as high risk. At that time, she received azacitidine again as a part of a trial. She responded well with complete remission for more than 2 years. Then again, situation became more severe. She started to bleed and suffered from thrombocytopenia, low platelet count. She received L-Thrombopag, a platelet stimulating agent, which was again in clinical trial at that time. She responded very well. And then 2 years later, she developed acute leukemia, still responded again to another trial of azacitidine. And 2 years or 3 or 4 years later, there was a deterioration, and she died at the age of 90 and 98. So this is really a good example of two patients, but see how we made a nice progress, although it is still a long way to go. A few numbers, epidemiology about MDS. As we all know, this is a disease of the AIDS decade, as I mentioned. Although young patients are diagnosed as well, the incidence increases with age. It is about 10, I would say on the average, 10 new patients for each 100,000 people every year. In the US, it is estimated to be between 15 and 25,000 new patients per year, little bit more common in males, little bit. And we assume that still the incidence and prevalence are probably higher, and many patients are still underestimated. Now, a few words about the biology of the disease. Now, the real cause is still unknown, but we know that several factors influencing the disease, such as chemical agents, organic solvents, radiation. We see patients who were exposed to radiation both in Japan as well as in the nuclear disaster in Chernobyl, Ukraine in 1986. Several drugs might be also offending drugs. We know that genetics is very important, although the hereditary role has a very limited role, which I will mention later. Also, in terms of the biology of the disease, we know that genetic and cytogenetic defects are important, and over the last few decades, there has been lot of research ongoing on the role of the immune system as well as inflammation. Even the term inflammation of aging, has been mentioned several times. And there was an excellent review on that by Uwe Platzbecker from Leipzig, Germany, in the last Marseille meeting. I took the liberty to show you one of the recent studies of our group in Tel Aviv, which also proves the role of inflammation in the biology of MDS. This is a small study in which we showed that CRP and celluloid markers of inflammation are higher in MDS compared with controls. Interesting phenomenon has been mentioned and described about a decade ago in parallel by 3-4 groups. And I would like to show you here one of the results of one of these groups, the group of Ben Ebert from Harvard in Boston. What they did, interestingly, they tested human beings, healthy people. And they tested, in fact, something like, I think, 17,000 people who were notified and defined as healthy people. And what they did, they sequenced their DNA. And interestingly enough, they found that as we are aging, there are more and more mutations which are found in healthy people. By the age of 79, 80, it comes to almost 10% of us are harboring mutations. And the risk to become sick is there, but is small. So the interesting point is that most of us will never be sick. But yes, some of us, and more as we are aging, are gaining mutations which put us at some risk to develop MDS and other diseases in the future. As we all know, chromosomal abnormalities are quite common in more than 50% of MDS patients at presentation, at diagnosis. And this is one of the reports coming from Germany, shows that basically there are many chromosome abnormalities that have been described in MDS, but the more commons are related to chromosome number 7, number 5, and others. About 20, 30 years ago, we, myself as well as others, believed that once we found the genetic mutation characteristic for MDS, our life and our patient's life will be easier. Well, it turned not to be the case. Here is a summary of our European MDS group led by Luca Malcobati. And here we show, and others have shown similar, that there are many myeloid mutations which are typical for MDS, not specific, but typical. And we can say today that almost every MDS patient has at least one mutation. Clinically, most of the information that we have, not only, but part of the information that we have is coming from several clinical trials as well as registry. And here I would like to mention the European MDS Registry, which we are part of. And we learned many symptoms and many features of the clinical picture from this European MDS project, which is an academic project which describes prospective longitudinal observational reports on patients with MDS. The project now includes people and patients from 22 countries. Initially, it was only low risk, but now also high risk patients. And there are now more than 3,000 patients in the registry. This registry really has allowed us to have many lessons on the clinical picture as well as other features of MDS. So as we all know, anemia, as I already mentioned, is the hallmark of MDS in more than 95% of the patients. More than them carry anemia and suffer from symptoms related to anemia. The anemia is typically macrocytic, so the MCV in the blood count is high. Sometimes there are also other cytopenias, such as leukopenia and thrombocytopenia. The symptoms are basically the complications of the anemia and the cytopenia. So weakness, fatigue are typical to patients with anemia. Cardiovascular heart problems are also typical to elderly people with anemia or patients who already have heart disease. Infections and bleedings are related to the other cytopenia. And as we already mentioned, the leukemic transformation is there for some patients with MDS. Another point which I would like to mention is the impaired quality of life, a topic which now is gaining more and more attention. So as we said, we in the European MDS group have published a paper led by Reinhard Stauder about 3-4 years ago, showing indeed that patients with MDS compared with healthy controls indeed suffer from impaired quality of life, which is characterized by problem of pain, discomfort, mobility, daily activities, anxiety, depression, and self-care. And it has been confirmed by others, including our group as well as others, that patients with MDS indeed suffer from impaired quality of life. Yael Herring from our group also studied that topic. And interestingly, we found that quality of life significantly is impaired while hemoglobin drops below 9 grams per deciliter. This might lead to a kind of paradigm change because currently most patients are transfused only when their hemoglobin is below 8. But maybe such a study like ours and maybe others may push the clinical community to consider transfusions even in higher hemoglobin threshold. So what are the challenges as I see it in the field in 2023? What about diagnosis? We must find better ways and new tools to better diagnose patients with MDS, maybe to diagnose them early, and also to try to identify individuals who are still sort of healthy but have the risk to develop the disease in the future. And the term pre-MDS has been mentioned in the professional literature more and more. In terms of the biology, no need to explain and to convince that better understanding of the disease might lead to better therapeutic options. We are now addressing more and more the quality of life issues in addition to prolongation of life and maybe cure in the future. In terms of low-risk MDS, we have to find more intelligent ways to treat the anemia. We still use transfusions, but maybe we can find something better agent. We have a problem with thrombocytopenia, which I will mention, and how to address the high-risk MDS patients. We still use azacitidine, but we want something better, and I will get to that in the next few minutes. So let's talk about diagnosis. We know that diagnosis is important, and we have to ask the question, can we diagnose patients or subjects even before MDS develops? And we can probably consider two types of tools that might help us. The one is genetic tools, and the other one is use the newly field of digital or artificial intelligence. And we know today that there are situations which are defined today as CCUS and ICAS, but states which are considered pre-MDS, in other words, people, subjects who are still healthy, but in the future may develop or may not MDS. So here is one study from our center. Joffe from our center asked the question whether we can identify patients with MDS earlier. And what he did, he took the electronic medical records of the community and followed backwards 420 patients with MDS. And when he went backwards to the electronic medical records, it is clear here is the hemoglobin, but it was similar also white blood cells and platelet count. And yes, the result is that at least some patients, and many patients in fact, can be detected. The decline of the hemoglobin can be detected earlier, and we have to find the ways to do that ahead of time and to minimize damage. Now, we know today that diagnosis of MDS is still based on bone marrow examination and still based on morphology. So we suspect the patient because of the clinical picture, because of the age, anemia, adocytopenia, high MCV. We exclude other reasons for the anemia, but then the gold standard of the diagnosis is made by examination of the bone marrow, in which we look under the microscope and see the features typical for MDS and different from normal. Yes, we add some other more modern techniques, such as cytogenetics, which we mentioned already, chromosome analysis, immunophenotyping, FISH, and also genetics. But still, we have to admit that in 2023, still the main tool of diagnosing MDS is bone marrow morphology. Now, we asked the question, we are still based on bone marrow examination, but we have to remember that this is still invasive and painful, at least to some patients. It might be associated with possible bleeding. It is difficult for elderly people, and it is subject to subjective interpretation of the pathologist or hematopathologist who looks under the microscope. So the question is, in 2023, are all patients in need for this examination? Can we diagnose, at least in some patients, can we diagnose MDS without bone marrow, at least in some patients? And here I would like to mention a study that was done in Tel Aviv and in the European MDS group, led by Howie Oster, who works with me. In 2 steps, I won't go over the details. In first step, we used patients from Tel Aviv and we compared them to control, but the more interesting part was done together with the European MDS group, in which we took 1,000 people and we compared 500 patients to 500 controls. All had bone marrow. We compared numerous parameters, and we ended up with a simple web algorithm using 10 parameters, which I'm going to show you, which can help in diagnosis or exclusion without bone marrow. Here you can see it's not that complicated as it looks. Here are the simple parameters: age, gender, hemoglobin, white blood cell count, platelet count, MCV, neutrophil count, monocyte count, blood glucose, and creatinine. And these are simple, easily available parameters that are available to every patient as well as every family physician in the community. And when you put these numbers, the individual values of the particular suspected subject, you can hit the computer and get this picture. If the blue line falls in the red, it's probably MDS. In the green, it's probably not. In this area, in the lavender, it is still questionable. And this is the link, and this is the barcode which you can use. An easy way to use it, and probably, at least in some patients, it might save or avoid the bone marrow. Now, obviously, such a model needs confirmation and validation. I won't get into the numbers and the whole details, but the group from Düsseldorf, Germany, led by Ulrich Böhming, just published and presented in the last American Society of Hematology meeting a validation of this model, and you can see the numbers. The positive predictive value is 87%, pretty good model. And we presented in Marseille meeting, which we mentioned. This is a study led by a resident from our group, Ariel Polyakov, and Ariel compared the data of 100 patients with MDS to 100 controls, people who did not participate, whose data were not taken into consideration in the building of the model. And again, very similar data, positive predictive value of 90%. So the model is pretty accurate. It's not accurate in 100%, but it's pretty accurate and valid for diagnosis and mainly for exclusion of patients with MDS. And it may allow some people suspected to avoid bone marrow. Now, another way is to use the modern artificial intelligence tools. And I tell you a secret, I know nothing on these things, so don't get confused. I know how to use them, or at least I know what questions to ask and whom to ask. So this is Betsy Katz from our center, who together with a startup company are trying to use the lot of information that can get from morphology of peripheral blood and put it with AI tools in computers and have different, as you can say, different patterns to controls and to MDS, and hopefully by that to diagnose MDS from peripheral blood. Another way, this is Liran Schluss from Weizmann Institute, who recently presented in the European Hematology Association in Frankfurt their work done in Weizmann Institute, in which they developed a system to have stem cells from the bone marrow, but to have them in the peripheral blood and to reproduce them, to increase the number, and by that to find genetics, cytogenetics, and to diagnose MDS as opposed to controls. Still, these are in evolution, but the bottom line is that we may be able in the next few years to diagnose MDS by peripheral blood and to save the bone marrow, which is probably not terrible, but obviously is invasive procedure. Now, prognosis and classification. Why do we need classification? Because classification allows us to put patients in the right group and to know, to predict the future, as well as to design the right treatment. So over the years, we have seen several types of classification. The first one was probably the famous French-American-British classification. This is the French-American-British group led by John Bennett, who recently turned to be 90. And by the way, John Bennett is also the founder, together with Peter Greenberg and others, of the MDS Foundation. And this French-American-British classification was the first one, number one, to suggest a classification, but number two, also to suggest the term Myelodysplastic Syndromes, MDS. Then we saw several other classifications, including the International Prognostic Scoring System, IPSS, led by Peter Greenberg from Stanford, California. And indeed, this classification allowed us to categorize the patients, to put them in a group lower risk as well as higher risk. Recently, which was also presented in the Marseille meeting, is the new classification, which is called IPSS-M molecular, which means that we are now incorporating molecular or genetic data in the classification. So in addition to the previous classifications, which included data on blood count, data on cytogenetics, this new classification presented by Elsa Bernard from Sloan Kettering in New York also incorporates genetic mutation. And what they did as a group, led by Eli Papa Emanuel from Sloan Kettering, New York, this is an effort of international group. And this international group collected data from about 3,000 MDS patients. And they tested and sequenced 152 genes. This is a huge and very complex project, but the bottom line is that they found that 31 genes are important for MDS. They compared it with the clinical data, the long course of the disease, the treatment that the patients received, and eventually they came up with the conclusion that by using this data of the blood count, cytogenetics, and genetic data, patients can be categorized into 6 groups: very low, low risk, moderate low, moderate high, high risk, and very high risk group of MDS patients. And interestingly, almost half of the patients, if we incorporate also genetic data, they were restratified and belonged to another group compared with the previous classifications. Why is it important? Because, as we said, because number one, we can better predict the future of the patient. And the second point, we can better adjust the appropriate treatment for the particular patient. So now let's devote the last few minutes for the treatment. Now, treatment, as we know, MDS is not really one disease. It's not really homogeneous. Many patients are different from each other. So the treatment is also should be tailored to the appropriate patient. So the treatment depends on the status of the disease, as we said, whether it is lower risk or higher risk. Then also we have to take into consideration the particular details of the specific patient, the age, other diseases, his functional status, and yes, over the last few years, we also take into consideration patient's preference, the quality of life, and also patient-reported outcomes, what they want and what really matters from them. Here I would like to mention the big project that we did in the European MDS group, which was published in 2019 online, and these are the European guidelines. We are now working together with the MDS Foundation on updated international guidelines, which hopefully will be ready by the end of this year. But you are welcome to get into our site and see in details the recommendations, guidelines for diagnosis, but also for treatment. So how do we treat, how do we approach patients with lower risk MDS? Let's start with anemia, which is a common and very significant problem. Now, still in 2023, we still use red blood cell transfusions to those patients who really need it. More than 50%, in other series, about 80% of the patients with MDS still require red blood cell transfusions. This improves the quality of life, but we have to remember that it might be associated with iron overload, which we have to take care of as well. Interestingly, importantly, the blood transfusion, in contrast with previous suggestions, is not associated with disease progression. So it's safe from the point of disease, from the point of view of disease progression. What is the hemoglobin threshold? In many centers, it is below 8 or below 7, but as I mentioned earlier, it can be, and in fact should be, individualized. What is the hemoglobin target? There is no really target as long as the patient feels better. And the frequency is also as needed. Here is the picture of my colleague Guillermo Sanz from Valencia, one of the pioneers of the research of this field. Erythropoietin, or erythroid-stimulating agent, or ESA, has been with us now for more than 2 or 3 decades as an excellent agent for the anemia of MDS. And it is still considered as the first line with or without red blood cell transfusion. It is very effective. It leads to hemoglobin rise, to fewer transfusion needs, and as again, to improved quality of life. And yes, it is safe. It is not associated with any disease progression. We in the European MDS group have studied several aspects of the ESAs, and again, we show that it's safe and it's effective. More interestingly, one of our papers led by Hege Garelius from Sweden showed again that there is no disease progression, and recently presented also in Marseille by Hege Garelius, and the study was led by Eva Hellström from Sweden. We compared patients treated with ESA to untreated, and it looks as there is also prolonged survival to MDS patients treated with erythropoietin-stimulating agent. Lenalidomide, the derivative of the old thalidomide, and there was an excellent review on that in Marseille by Mikhail Sekeres, previously in Cleveland and now in Miami. And I would like here to mention the main research projects, the MDS 004, which we participated in, led by Pierre Fenou, showed that indeed mainly patients with del(5q) respond to that, but also another study led by Valeria Santini. In this study, we also showed that some patients without del(5q) may respond as well, but still in many countries, the lenalidomide is reserved mainly for patients with MDS who have anemia and have mainly the del(5q). Recently, a Spanish trial, which was presented in Marseille, also asked the question, probably by using lenalidomide before transfusions, we can delay the transfusions. The answer is apparently yes. Luspatercept is more new agent, and the luspatercept is active in red blood cell production. Initially, there were phase 1 and phase 2 trials, which were led by some people, including Uwe Platzbecker, with promising results. And then came the medalist trial, published about 2-3 years ago, led by Pierre Fenou, which showed that indeed the luspatercept is safe and is active in patients who were refractory to erythropoietin. But the more recent trial, which was recently published in the ASCO, as well as in the European Hematology Association, this is the COMMANDS trial, which was presented by Guillermo Garza-Manero, by De La Porta, and recently published by Uwe Platzbecker in Lancet. And this study, the COMMANDS, showed that luspatercept as first line is probably better than erythropoietin. And this leads us to the question, what will be the first line in the future? Will we use for these patients with MDS luspatercept first or erythroid-stimulating agent first? And this is a still open question, a question that, by the way, we are going to discuss in the Friday Satellite Symposium of the coming American Society of Hematology in the MDS Foundation Symposium in December. Other experimental agents are possible, and I will just mention very briefly azacitidine oral, imetelstat, AG, roxadostat, Matterhorn, a study which was published recently. So there are some interesting experimental agents on the way. With the interest of time, I'm not getting into details, but yes, there is something to look for in the future. What about thrombocytopenia? Low platelet count indeed is a problem in many patients with MDS. We still use platelet transfusions. There are two agents which are stimulating platelet count, romiplostim and L-thrombopag, and they are effective, but several safety concerns have been raised. I am asking if it's justified because I have personal reservation about that. But yes, I have to admit that the development of these agents is currently frozen because of this safety concern. There are new agents on the way, so I hope that in the future we will be able to have better, more effective treatment for the thrombocytopenia. What about high-risk patients with MDS? The standard treatment for high risk can be either anti-leukemic treatment, but as we know, most patients are not candidates for this treatment. So hypomethylating agent, especially azacitidine, as Pierre Fenu and others have shown, is the current standard of care. But we have several problems because still it might be aggressive. The response rate is not high enough as we would like to. It's about 50%, and it's limited in duration, about 2 years. And we are trying to do better. So how can we do better? And this issue was very nicely touched by Lionel Hades from Hôpital Saint-Louis in Paris in the recent Marseille meeting. And he listed several possibilities of improving the current results of high-risk patients, such as treating the complications and the problems with the hypomethylating, using hypomethylating in a different way, and mainly combinations of hypomethylating with other agents. Venetoclax is probably the one that is gaining now more attention. And yes, we still can use the old ways of chemotherapy as well as novel agents. So what novel agents are possible? This is a very busy slide. I'm not going to go over the details. I will mention that several agents, Glastegib, Selinexor, Pevonedistat, Rigosertib, and Lenalidomide, are considered today as failure, but I can tell you that I'm not sure because I still think that some of them can still be saved. More interesting are these studies which are still open. The Verona trial is testing the combination of AZA and venetoclax, and as I mentioned, venetoclax is probably the one today is the front runner as an agent to be added to azacitidine. There is a still stimulus trial which is still open with sabatolimab, an agent of Novartis company, and we are also waiting for the Gilead trial with the enhanced trial with the magrolimab anti-CD47 in addition to azacitidine. Also, there are other agents which are on the way, more targeting, trying to target specific problems or specific mutations. And here I would like to mention Guillermo Garcia Manero from MD Anderson, one of the pioneers in the field. There are several agents trying to attack the TP53 mutations. Others are trying to address or to inhibit IDH1 and IDH2 mutations. And more recently, there are also anti-inflammatory agents, which are very promising in the beginning, but promising. I would like to mention that stem cell transplantation is always a possibility, although it is appropriate only for a minority of patients because of the age and because of other complications. But yes, this is something to consider, at least in the more younger patients. So in summary, how do we treat patients with MDS in 2023? Don't forget the supportive treatment, transfusions, red blood cell transfusions, platelet transfusions, ion chelation, and other palliative measures. The lower risk patients are treated with growth factors, mainly erythropoietin, others with thrombomimetics for the thrombocytopenia. We mentioned lenalidomide, and recently the luspatercept. In high-risk patients, the hypomethylating AZA is still the first line, but probably we should add to that something. Venetoclax is currently the front runner in many trials, but other agents are possible as well. And yes, anti-leukemic treatment is possible for the younger patients as well as others. And yes, experimental treatment are now in many, many trials tested. As I mentioned, you can find this summary in the European MDS website, and now we are developing new guidelines. Almost last point, why do I recommend many of my patients to participate in clinical trials? Because it's the way to access novel treatments. It allows better follow-up. It is free treatment usually. There is no need to pay for that. It helps the people, it helps the science. And yes, I advise everybody to ask and to join a clinical trial if it's possible, if it's available. One of the problems that we are facing is the financial toxicity. This is what happened to one of my patients who got a prescription and went to the pharmacy, and the pharmacist told him that the drug has no side effects, but the price might make him dizzy, and you can see here that does not make any difference what currency you are using. This is one of our problems. Interesting to remember what the famous philosopher Voltaire said: physician is a man who pours drugs of which he knows little into a body of which he knows less. I think we are changing this. We now more. Now, it's very important to remember that I agree with you that it's better to be young, rich, and healthy than the opposite. But yes, I think that if we have to be in the opposite side, we are doing now better and better. So the future, I think, is promising and encouraging. We are going to use modern tools. We are going to be better. We are going to use less invasive techniques. We are going to have more and more collaborative and international collaboration. And this will lead to personal approach, which will be better. And this is my grandson looking at the promising future. I have to thank all the people involved in the study that I presented, people in Tel Aviv, as well as the European MDS group, and obviously a big thanks to the MDS Foundation for all the work. I like working with Dr. Steven Neimer, the chairman, CEO Tracy, as well as Leah Harrison, who helps us in the MDS Foundation. And with that, I finish, and obviously I'll be open to questions either in this forum or later on online. Thank you, and I wish you good health and good quality of life. Thank you.
Thank you, Dr. Mittelman, for your wonderful and informative presentation. If you haven't already done so, please submit your questions in the chat box on the bottom menu bar on the screen. We will now proceed to the live Q&A.
Maybe before people start, I can start with one or couple of questions that I have received in the meantime, Janice.
That would be wonderful. Thank you, Dr. Mittelman.
Okay, first of all, I would like also to add, by mistake, I forgot to add Janice or the team of MDS Foundation, so it's never too late to admit a mistake and to correct it. This is a mistake that can be corrected, so thank you, Janice. Now, as for the questions that I have received in the meantime, there is one question that is repeatedly being asked: is MDS hereditary disease? Patients are concerned that they might transfer the disease to their children and grandchildren. So I can say, basically, the answer is, in general, no. MDS is not considered hereditary disease. There is a subset, a small percentage of patients who have kind of hereditary problem, which might lead to MDS, but this is really the exception. Most patients do not have hereditary disease, and there is no reason today to test the children or grandchildren and so on. Another question which I've been asked recently, as well as in other situations, how do I see the future? Will we treat in a different way? So I would say, MDS and medicine in general is an evolving issue, is an evolving field. I believe in evolution, not in revolution. So we are making progress, and part of it, obviously, I have tried to explain in my talk, but I think that in the next few years, and actually I showed it in the last slides, I think we will have better tools which will be more effective, less invasive, less toxic, and probably the word that we are using more and more is individualized and personalized medicine. So we'll be able to tailor the right suit to every patient.
Very well said, Dr. Mittelman. I do have a question for you from an MDS patient. How long does it take to determine if luspatercept is effective? Is it weeks, months?
That's a good question. Well, in fact, like many other novel agents, we are all studying it. So maybe some of the things that I will say now may turn to be not exact in the next few weeks or next few months or next few years. But as far as we know today, luspatercept is indeed a novel agent, very effective. Initially, as I showed, it has been shown to be effective in patients with lower risk MDS and anemia who have lost their response to erythropoietin or even did not respond to begin with. And it was successful as second agent. But more interestingly, recently, the COMMANDS trial, which was recently presented in several meetings, has been shown to be even better as first line. Now, how long does it take? It seems that it takes a few weeks. So something between 4 weeks to 12 weeks, if you want, between 1 month to 2-3 months. And if there is no response after 2-3 months, probably the patient has not responded. We are talking about more than 50-60% of the people that might respond. So yes, the patient has to be patient before we know how it is going. And it is possible that we have also other agents, other new agents, and maybe some kind of combinations, but the future will tell us.
Thank you, Dr. Mittelman. I have another question for you. How many transfusions would a patient need to receive before iron overload is concerned?
Well, I would, with your permission, I would split the question to 2 parts. How many patients, how many transfusions can a patient receive? And when do we define iron overload? Well, the first part of the question, as many as patients need. It is important that the patient would feel well. It is important for the quality of life. It is important to maintain the systems, especially the heart system. So yes, we do not leave a patient with significant anemia being untransfused. When to start, as I said, in some centers, in some countries, they wait to the patient to be less than 8 or less than 7, but it's individualized, depends on the patient, depends on the policy of the center. But yes, we transfuse patients in order to make them feel better and to maintain the necessary body systems. Now, as for iron overload, there are several definitions, and it's not completely clear. According to simple definitions, we can say that between 20 to 25 total cumulative number of blood transfusions or serum ferritin level of 1,000, usually this is what we define as iron overload. However, there are several research projects that showed that probably these numbers are quite arbitrary, and other parameters such as labile ion in the plasma and other parameters might be more important. But I think the important point, the take-home message that I would like really to deliver is number 1, if a patient receives more than 20-25 total cumulative units of blood, we should be treating also iron overload, And number two, yes, there is an effective treatment for iron load today, which in some cases are not really used. So don't forget the iron overload and don't forget to treat it because there is effective treatment for iron overload.
Thank you, Dr. Mittelman. And I have another question from Kay. Does luspatercept help with fatigue?
Luspatercept interfere with the teeth? That's
Help
the
with
question?
fatigue. Does it help with fatigue?
I am not sure that I understand really the question, not as far as I know. But as I said, this is a novel agent. And, you know, I remember that in several other novel agents, we found some of the effects as well as the adverse effects only later. But I have to admit, not that I know.
Okay, thank you. Another question, has there been any research on the impact of pantothenic acid, vitamin B5, on MDS-related anemia?
Well, there has been several studies testing several types of vitamins. And I have to admit that some of them were very encouraging to begin with, but they never materialized enough, except for some time pyridoxine B6. But in general, I can say that we still don't think that vitamins is a solution for MDS, not yet.
Okay. Another question, I've seen some research on the combination of growth factors for white blood cells on azacitidine. Can you speak about that?
Yes, as I mentioned, azacitidine or Vidaza is an agent which belongs to the family which is called hypomethylating agent. And these agents, in fact, there are two such agents today, decitabine and azacitidine. And these agents are considered today the first-line treatment for high-risk MDS. And in fact, they are effective. But as I said, it's time to move on and to be better. What do I mean by better? We would like to increase the response rate because not everybody responds. We want those who do not to respond. And also, there is a limit to the duration of the response, usually on the average 2 years. I have a patient which I saw this week who has been responding to azacitidine now for more than 12 years. And in fact, I stopped it a year ago, and the response is still maintained more than 12 years after. But usually, most patients have a limited duration of response. So yes, there are many efforts, I should say, to increase the response rate and or to prolong the duration of the effect. And one of the ways is indeed to add growth factors. And the idea is that some of the growth factors have anti-MDS effect. And the other effect is to treat the neutropenia and thrombocytopenia related to the agent. And by that, to be able to give more AZA and on time. More important is the addition, as I mentioned, of several agents to Vidaza. I mentioned the venetoclax, probably today the more commonly used. Others which are still under investigation, I would like to mention the sabatolimab. This is an antibody, anti-TIM3 of Novartis. The study has been completed. We are still waiting for the results. Another interesting possibility is the magrolimab, the anti-CD47 antibody. The enhanced study of Gilead company is still ongoing, and we are looking forward for the results. So it looks like that in the future, we will be able to take Vidaza or AZA and to add something, whether it is growth factor or venetoclax or another agent or any other combination. It is still too early to say, the bottom line of the answer of my question, still AZA is the only approved, proven first-line treatment, but we are getting close to combination which will include AZA and other agents, but I can't say for sure that it will be growth factors or venetoclax or others.
Thank you, Dr. Mittelman. I have a question from an MDS patient. I have been taking Promacta for low platelets since May of 2023, now taking 150 milligrams a day. It's costing $2,000 out of pocket a month. My platelets hover around 29 to 31. If I am advised to increase the dosage, what is your advice? Just had a bone marrow biopsy and I had no transformation to AML. Also, currently, I am not taking anything for anemia. I've had 4 transfusions in 9 months when my HGB was around 6. Should I be asking about the drugs you mentioned, even if I do not have deletion 5q? I only know that I have a trisomy of chromosome 19.
Well, as you know, Janice, it is always difficult to answer questions for individual patients without knowing and having the whole history and the whole information. But
Right.
I will take advantage of this particular question and try to answer or to focus on several points which might be important to other people as well as to the patient who asked the question. Number one, we have a problem of platelet count, low platelet count in about 20 to 30% of the patients with MDS. And as I mentioned, platelet transfusions can always be given, but we are trying to use this method only when the platelet count is very low, and very low, I mean below 20 or even below 10,000. So usually in the platelet count of 29 or 39, as the question says, usually if there is no clear-cut bleeding, we prefer not to give platelet transfusion. Don't forget that platelet transfusion, number one, is difficult to achieve, and number two, it causes kind of sensitization, which makes the next transfusion more difficult. So usually we transfuse platelets only when the count is very low, not 29, and or when there is indeed bleeding, or when the patient is going to have surgical procedure. These are the 3 indications. And if my patients are stable with no bleeding, even at the platelet count of 10, 15, 20, I don't transfuse. Now, as for the anemia, again, the question is how severe is the anemia? And we specified the ways to treat anemia. One last point about platelet count, as I said, unfortunately today, still there is no effective agent that has been approved because of the safety concern, but I'm really optimistic that it will be available in the next couple of years, because I know of at least 2 agents that are on the way to be tested in clinical trials. So I think I tried to answer in general the question, but definitely it's difficult to address specific points of a particular patient.
Right. I have another question. Do we know what percentage of patients with CCUS/ICUS go on to develop MDS?
That's a good question that the answer is really not completely clear today, but is being clarified. I will explain in more details. As I mentioned, we know today there are several conditions in which the patients might or might not develop MDS in the future. And this is called, and we define it in general as pre-MDS states. But how exactly to define each and what's the exact percentage is still unclear. I would say, if I have to give a number, to provide a number just to be to have the idea, it's about 20-25%, but it really just a gross number, and one has to be careful. So how are we going to address it? There are more and more clinics in the world that are taking these patients and following them. There are several ways, as I explained, to detect these patients and to follow. And I presume that within the next 5 to 10 years, we will have better idea about the exact numbers. It will suffice today to say that those who have any feature that might put them in the pre-MDS state, and this can be low platelet count or low hemoglobin or low white blood cell count without any other reason, and or a genetic mutation that has been found by chance or by any other reason, these patients might be followed, not too closely, but followed, but I can't say for sure if the percentage is 10% or 15% or 25%. I would say that in the general population, as I said, it is very, very low.
Thank you. I have another question. Has there been an increase in clinical trials for oral therapies?
Increase in clinical trial for?
Yes, has there been an increase in clinical trials for oral therapies?
For oral therapy?
Yes.
Yes. Basically, the answer is yes, but I will say in a more general way. We as physicians, I think we did not pay enough attention, I would say, in the past to issues that are very important to many patients. As I said, quality of life and other issues. This has been corrected, and it's good that it has been corrected over the last decade, and more trials are addressing these issues. So the attempt to develop oral agents, and by that to skip the need to give injections or infusions, is definitely a significant one. I can mention something which I showed very quickly. There is an interesting study led by Guillermo Garcia Manero from MD Anderson. We participated in that also, and we gave patients with intermediate risk MDS oral azacitidine. This is still being developed. And I also mentioned the L-Thrombopag for the platelet, which is oral. So yes, there is an attempt to develop more oral agents, and obviously this leads to trials, but unfortunately not every agent can be given orally, and still we are using injections, shots, and transfusions. But as I explained also with the bone marrow, I guess that the world is moving towards less invasive procedures and less invasive and less toxic and easily to use agents, therapeutic agents as well.
Thank you, Dr. Mittelman. What genetic mutations put you at higher risk for transformation to AML?
Well, there is no really specific single mutation that we can say that if the patient has this particular mutation, he will transform to acute myeloid leukemia. This is not the case, at least not yet. But we know to classify, as I explained, patients to the lower risk and high risk group. We are using today more and more, if we have genetic information, we are classifying the patients also according to the IPSS-M, which means also that we can include genetic information and the mutations that we know into this. And once the patient is classified as being high risk, we are always taking into consideration that the chances and the risk to develop acute leukemia is significant. And one of the purposes of the treatments is indeed either to delay or also to prevent the development or the evolution into acute leukemia. But again, there is no particular mutation which I can say that if this particular mutation exists, the chances of leukemic transformation are high.
Thank you. Another question. Has there been any research into the use of PET scans for diagnosis, or would it have to come through blood work?
PET scan, the question is PET scan. Well, PET scan is a very commonly used technique in many patients with hematological as well as oncological disease. In MDS particularly, it has not been too useful or helpful. So the reason to use PET is only in patients who have a local problem, which I want to see, but relatively, I don't use a lot of PET for patients with MDS. On the other hand, as I mentioned in my talk, and I think the question allows me to focus and to emphasize that point, we are in the era in which we are doing more and more blood tests, which is almost non-invasive, except for the stick to take the blood from the vein, and taking more and getting more and more information from the peripheral blood, hopefully will replace information which is today still obtained from the bone marrow. And I showed some examples, and I hope and I think that within the next few years, we will see more and more studies and, in fact, application of methods in which information, which is very important, is obtained from peripheral blood, non-invasive technique, and in contrast with the bone marrow, which people may say that it's not terrible, but we will all agree that it is quite invasive procedure.
Okay, thank you, Dr. Mittelman. Just as a reminder, please, if you have any questions, submit your questions through the Q&A in the bottom menu bar, and Dr. Mittelman will answer them live. I have another question. Is there anything patients can do to help with fatigue other than receiving transfusions?
Other than receiving transfusions? Well, we are treating the problems and we are treating the findings. So if the hemoglobin is low and the patient is symptomatic, these are the two criteria, we give transfusions. Obviously, when a patient has anemia, symptomatic anemia, he is a candidate for treatments, as I mentioned, either erythropoietin, luspatercept, and so on. If the patient has higher risk, obviously, he is a candidate for treatment for high risk. But if the patient has only low risk MDS and he is minimally symptomatic or not symptomatic, there is no need to treat because no research so far has proven that the prognosis is better if we start earlier. So we are treating only the symptoms and the problems, and there is no, in contrast with other diseases in which you should probably treat earlier to prevent complications, this is not the case with MDS.
Okay, thank you. Does anybody have any more questions? Oh, we got another question for Dr. Mittelman. Where can I find more information on new therapies for MDS as results are released? With all of the information online, it gets hard to follow.
That's a question, Janice?
Yes, they just want to know where they can they find more information on new therapies for MDS.
Oh, I see. Well, the answer is that information, the first thing we have to distinguish between approved agents and experimental agents. It's very important. Some of us, including patients, families, as well as professionals, sometimes are not making the distinction, and it's important. Now, approved agents, it's easy. They can be found in the MDS Foundation site, as well as I mentioned the Europe MDS, the European MDS group site. There you can find definitely information about diagnosis as well as treatment and the various treatments, including the recently approved. Now, as for experimental, there is a site which is called clinical trials, but also in these sites also you can find often information on clinical trials. And I am also sure that the physician, the treating physician, can tell you about trials and about experimental agents. But remember that these are experimental, and with all the reservations, and not necessarily is appropriate for every patient.
Okay. We have a question from Bonnie. I have MDS MPN overlap with thrombocytosis. Do you have experience with this disease? Are there standard treatment options? Her oncologist says she will need a bone marrow transplant within 5 years.
Yes, you're talking about a variant which is called MDS MPN, which is kind of a transitional state between classical MDS, which we talked about today, as well as another disease, which is called myeloproliferative neoplasm, MPN. So this is kind of mixture between two diseases. And this MPN is characterized by high platelet count, thrombocytosis. Now, the treatment in such patients is basically both. We have to define what's the main problem. If the problem is thrombocytosis, so this should be the focus of the treatment. And thrombocytosis, if it's too high, might be associated with the risk of thrombosis. And this is why we have to maintain relatively lower platelet count and to prevent thrombotic complications. Now, another aspect of these diseases is really the bone marrow problem. And I can't say that this particular patient may need stem cell transplantation because it's too, I don't have enough information of this particular patient to say, but the problem is indeed the bone marrow. And if the disease is indeed progressing, and if the patient is young enough, then it is probably right that the physician sees for the future, aggravating condition, and bone marrow transplantation might solve the problem, hopefully. But the bottom line of this question, yes, this is kind of mixture of two diseases, and the treatment should be individualized based on the main problem, whether the problem is more MDS or more MPN. I suspect that this particular patient is mainly thrombocytosis, which is more MPN than MDS.
Okay, thank you, Dr. Mittelman. Great explanation. I have another question from Karen. She's high risk, just completed third cycle of AZA. Are there any dietary choices to avoid or that would help? And she said, you also spoke about vitamin B6.
Yes, this question allows me to say and emphasize several points. Number one, azacitidine is indeed still the first line and the approved treatment for high-risk MDS. And I hope and wish the patient to respond and to benefit from this treatment. I would like to emphasize that we don't see the response usually before 3, 4, and sometimes even 6 months, 6 cycles. So maybe after 3 cycles, it is still too early. That the patient, as I said, has to be patient, and sometimes and often the response is not obtained before 4, 5, 6, and sometimes more months. So still it's too early to evaluate it. The second point, we try to add something to the AZA in order to increase the response rate and the chances to respond. As I said, probably venetoclax, if not venetoclax, something else. but we are trying to increase the possibility to respond. The third point is referring to the diet. Unfortunately, there is no particular diet which I can recommend because there is no research that has been proven that a particular diet helps. However, it's always the case to say, and I guess that you don't need to be a doctor to say, that good diet, healthy diet is always beneficial to maintain good immune system, to maintain good health. So I think good healthy diet, and I don't have to specify what it means, can be helpful. But I can't specify and say that a particular diet has been recommended, not in MDS in general, and not in other treated patients in particular.
Thank you. We have another question from an MDS patient, and they want to know, does exercise help with the symptoms of fatigue? Or should you exercise even if you feel fatigue?
Yes, exercise, again, I think that all that I've said on diet is probably also right for exercise. I can't say that there is a research that showed that exercise indeed is helpful. But on the other hand, I am sure that exercise in general and exercise in MDS in particular is helpful in maintaining the good health, the good feeling, and I think the fighting chance. And I encourage my patients not to stay at home and not to lie in bed, but to exercise. Obviously, one has to listen and be careful about the body, and you cannot expect if the hemoglobin is 8 to be able to do exercise like you were able to do when the hemoglobin was 13 or 14. But exercise, yes, definitely, although I cannot mention a particular research that proved it, but it's clear and it's acceptable. Exercise, yes.
Thank you. Another question, does the new IPSSM also give median life expectancy in years?
I'm sorry, can you repeat IPSSM what?
Does it also give median life expectancy in years?
Yes. The answer is yes, but I think, frankly, I think this is less important. I think more important is the message that because in more than half of the world, maybe in many parts of the world, unfortunately, due to financial restrictions, genetic testing are still not available. But the main take-home message is that if genetic testing is available, then we can introduce and incorporate the results into the classification, and by that we can better classify the patient. And as I mentioned, there are 6 groups, and obviously the survival and the prognosis is in accordance, and that also directs the treatment. If there is a relatively young patient and the disease is more severe, we are trying to be more aggressive with the treatment. And on the contrary, using the molecular or the genetic testing, if the disease is not that severe, maybe we can be more liberal and not that aggressive in the treatment. So I think this is much more important than really the numbers.
Thank you. The question from Deborah. Please comment on a Imetelstat impact on the disease variable allele frequency.
I'm sorry, you will have to repeat it.
Please comment on Imetelstat impact on the disease variable frequency.
Sure. Imetelstat is another new agent which is still investigational and still in experiment. The mechanism of imetelstat is inhibition of telomerase. I can explain that telomers are part of the DNA, which are probably related to life and to survival of the cell. And telomerase is the enzyme that makes the telomeres short. And we have evidence today that in several diseases, including MDS, there is an increased telomerase activity, which makes the telomeres shorter, and this is part of the biology of the disease. So this led to the development of agents which are inhibiting telomerase, and imetelstat is probably the first in the group. We are also participating in the trial. Trial is called IMerge. This is a trial of the Geron company, in which we treat patients who already had been treated with erythropoietin and either lost the response or did not respond to begin with. These patients receive either imetelstat or a placebo. So we don't have the results of the study yet. There are 2 or 3 reports, one published by Uwe Platzbecker and presented, and we are talking about response of about 50%. So yes, it is effective, not in everybody, but it is effective in patients who lost the response to erythropoietin, and it might be effective. The agent is given in infusion once every month. It is quite tolerable. I can say that from the patients that I treated, there were no really significant adverse effects. And obviously, it might be one of the important agents in the future, but don't forget, it is still under investigation, and there is still many open questions. But imetelstat, yes, possible in the future or today in a part of a trial.
Okay, great, thank you. We have time for another question. Can a patient stay on eltrombopag indefinitely if none of the risks discussed materialize?
Well, I'm not sure that I answer well the question, but I can tell you what I know. Eltrombopag is an oral agent which has been shown to be effective in increasing platelet count, as well as reducing the need for platelet transfusions and minimizing significant bleeding. So it has been shown to be effective. It is similar to the other agent, romiplostim, which is given by infusion or by injection. Unfortunately, and fortunately, there are about 10, 12 trials. We also participated in some, which have been shown to be effective. Unfortunately, there are 2 trials in which there were safety concerns. In other ways, there appeared that there were several patients who received the drug that progressed or even developed acute leukemia. This prompted a stop in the development, and unfortunately today, these 2 agents are frozen, and currently there is no really approved agent for patients with MDS and thrombocytopenia. I myself, but again, I am emphasizing that this is my personal view. I think this is too tough, and I hope that in the future, 2 things will happen. Number one, the embargo will be lifted, and the development will be renewed. And number 2, which I am more optimistic, there are 1 or 2 agents on the way. Unfortunately, today, we don't have effective agent, but hopefully in the near future, we will have. And all that I've said is also relevant to eltrombopag as well as to the other agent, romiplostim.
Okay, thank you. Hopefully we can fit in one more question from Karen. Please repeat the ferritin level when chelation should be introduced.
Yes, usually we use the round number 1,000 microgram per ml of serum ferritin level. But I have to emphasize again and I said it before and I re-emphasize it. It's very difficult in medicine in general, and here in particular, to refer to a particular number. Medicine is not judged by numbers. Many research projects have shown that this is not really the ferritin level, and there are other parameters, as I mentioned, such as labile plasma ion and others which are more important. There are other studies showing that the net effect of the ion overload on the organs, such as the liver, the heart, are more important. So there are several other parameters. If we try to be simple, I should say that once a patient receives more than 20-25 units of blood, cumulative dose together, or the serum ferritin level is 1,000, this is a good time to consider ion chelating agents. But again, we should address the number of 1,000 with caution.
Thank you so much, Dr. Mittelman. That's all we have time for today with our questions. I want to thank you again, Dr. Mittelman, for your wonderful presentation and for donating your time today. This presentation, thank you, Dr. Mittelman. It was nice seeing you.
Thank you, everybody. It has been my pleasure.
And this presentation will be available on the MDS Foundation website for on-demand viewing within 10 business days. If you have any questions unanswered, please email me at jbutchko@mds-foundation.org. Please see the link to our evaluation that we would like you to fill out, our patients and caregivers, family members. We appreciate your feedback. So please take the time to fill out our online survey. This concludes our presentation for today. On behalf of the MDS Foundation, thank you all for joining us and have a great day.